Good afternoon, everyone. Bancroft Neuro Rehab welcomes you to our Heads Up webinar series. For those of you unfamiliar with Bancroft Neuro Rehab, we are a premier provider of post-acute neurologic rehabilitation, offering residential and day services, neuropsychology, and outpatient therapies at our 3 locations throughout southern and central New Jersey, Mount Laurel, Plainsboro, and Toms River. Bancroft Neuro Rehab is a division of Bancroft, a provider of programs and services for individuals with autism, intellectual disability, and other neurological conditions. Today's program is oral health care, more than just brushing your teeth. We'll have time at the end of the presentation today for Q&A. And now I'm going to turn the presentation over to today's presenters, speech therapist Cerise Carmody-Sapp and occupational therapist Lisa Golod.
Thank you all for joining us this afternoon. I'm Cerise Carmody-Sapp, one of the speech-language pathologists here at Bancroft Neuro Rehab. Myself and my colleague Lisa have nothing to disclose at this time. Just before we get started, I wanted to extend a special thank you to some of our recent speech therapy graduate students, Christine and Lindsay, who put a lot of time and work into researching this topic and preparation for this presentation today. So following this presentation, our hope is that you'll be able to understand the importance of oral care in general and as a component of the medical intervention, to describe the proper techniques for brushing, flossing, and caring for dentures, to be able to address common barriers you might encounter across the rehab continuum, and to be able to implement some adapted approaches to oral care for people with different kinds of challenges. So I'd like to start by discussing some statistics related to oral care. About 25% of adults 60 years and older no longer have any natural teeth. Being disabled, homebound, or institutionalized increases the risk of poor oral health. And Americans with the poorest oral health are those who are economically disadvantaged, may lack insurance, or are members of racial and ethnic minority groups. So there are numerous benefits of oral care that we're going to discuss in detail as we go, but here's just a brief overview. So you're going to hear me keep saying that oral care, it's not just an element of grooming, but it really is a medical necessity. And that's because oral care can be seen as, the mouth can be seen as a window into the health of the whole body. And poor oral care can lead to all different kinds of medical complications, including periodontal disease, which is an infection caused by an inflammation in the gums and in the bone. The earliest stage of periodontal disease is called gingivitis, and that's characterized by swollen and bleeding gums. Later stage is called periodontitis, where the gums actually pull away from the teeth. You can have bone loss, the teeth may loosen and fall out. And periodontitis is known to be associated with other disorders of the cardiovascular, gastrointestinal, and respiratory systems, and they're currently researching an association between memory loss and confusion. Another condition that may result from poor oral health is dental caries. The simpler, more common term would be tooth decay or cavities. This is caused by bacteria on the teeth that can break down the tooth enamel, and inadequate oral cleaning can result in dental caries. Poor oral health also causes different types of oral infections that can spread to other areas of the body. I mentioned loss of teeth. This can impact one's nutritional status, their appearance, maybe their sense of self, and their overall quality of life. Halitosis is better known just as bad breath, and it's caused by rotting food particles in the oral cavity. Odor-causing bacteria feeds on these food particles and causes that bad breath. Periodontal disease can also be a culprit. So it's very important to discuss the concept of oral biofilm when we're talking about oral health. So first of all, oral biofilm is naturally occurring. We all have different types of microorganisms that are supposed to reside in our oral cavity. And they actually serve as a natural barrier that protects against the colonization of disease-causing pathogens. But it can be problematic if oral biofilm is allowed to grow unchecked. It can result in different types of oral infections and can lead to other diseases. But the good news is oral biofilm can be easily kept in check through adequate oral hygiene. I really like this image that was included in an article by the American Dental Hygienists Association. I think it does an excellent job of showing the complexity of how oral infection can lead to diseases in other areas of the body. So here are some of the different medical complications that can be a result of poor oral health. So one condition is cardiovascular disease. Now, an atheroma refers to a buildup of materials that adhere to our arteries. And what's very interesting is that when researchers took a look at the composition of these atheromas in people's arteries, they found that 40% of them actually contain antigens from periodontal pathogens, which means that the pathogens had traveled from the oral cavity to arteries and other areas of the body. Atherosclerosis is where you have this buildup of plaques in the medium and large muscular and elastic arteries, and it increases the risk for thrombosis, which is where blood clots can block the veins and arteries. And having thrombosis increases the risk of stroke, myocardial infarction, which is more commonly known as a heart attack. Endocarditis is another condition that affects the heart. It's actually an infection in the inner lining and the chambers of the heart, as well as the small valves of the heart. And what happens is infections spread through the circulatory system and enter the heart. And they found that there is a connection between increased risk of bacterial infection when someone has had dental procedures, which really makes sense. If someone has poor oral health, they're likely to require oral or dental procedures, then their risk of infection increases and the bacteria can travel to the heart. So pneumonia and aspiration is always a big concern of speech pathologists. Just in a general sense, pneumonia refers to having inflammation in the lungs, which can be caused by different types of bacteria, viruses, and fungus. Our lungs have air-filled sacs, and in pneumonia, these sacs become full of pus and fluid. And this condition really can be life-threatening. In many cases, pneumonia is treated with antibiotics. There are certain types of pneumonia that can be prevented by vaccine, but aspiration pneumonia is not prevented by vaccine. Now, when I'm talking about aspiration, what I'm referring to is the inhalation of food, liquid, vomit, or other secretions. Speech therapists treat a condition called dysphagia, which refers to any kind of dysfunction in the process of swallowing, whether it be in the oral, pharyngeal, or esophageal phase of the swallow. And having dysphagia increases the risk that someone can aspirate or inhale food and liquid. There's different ways that aspiration can be classified, but what can be most concerning is a problem called silent aspiration, where foreign material is allowed to enter the airway without any type of protective reflex. So naturally, our body should protect itself by coughing or clearing your throat when you feel the sensation of aspiration. It's that feeling we've all had where something goes down the wrong pipe. But in silent aspiration, that sensation is missing, that protection is missing, so the person is unaware that they're aspirating. Just to backtrack a moment and to connect how dysphagia is something that speech pathologists deal with in the neuro rehab setting. Dysphagia is often caused by neurological damage, such as in a stroke or traumatic brain injury. It could be the result of a progressive neurological disorder such as Parkinson's, Alzheimer's, other types of dementia. You may see individuals with dysphagia because they have head and neck cancers, might even be caused by some of the treatments for cancer. It could be part of the aging process. And also, just to connect back to oral health, periodontal disease can cause tooth loss, and then tooth loss can affect the oral phase of the swallow. Okay. Another condition that's associated with poor oral health is diabetes, and that includes both type 1 and type 2. And researchers are taking a look at potentially a two-pathway relationship to periodontal disease and diabetes. On one hand, diabetes increases the risk of having periodontal disease. But in addition, having periodontal disease when you already have a diagnosis of diabetes tends to increase the risk of having a more severe disease progression. So xerostomia is better known as dry mouth, which might sound like it's not something very significant. But in fact, dry mouth can be a very serious problem. What happens is the salivary glands in the mouth aren't producing enough saliva to keep the mouth moist. So this can be a result of many different types of medications that are commonly prescribed. I'm not going to list them all, but you've heard of many of these medications that treat depression, blood pressure and heart medications, decongestants, stimulants. I'm sure many of us have been prescribed medications like these, and the people under our care are frequently prescribed these medications. So it's helpful to be aware that they may be struggling with dry mouth. So saliva plays a very important role in our health. It initiates digestion. It starts the breakdown of starches and fats when we're eating. And it actually restores calcium and phosphate to our tooth enamel, which helps to protect against dental caries. So if someone is struggling with xerostomia, they can develop different types of oral infections, such as thrush, which is an infection from an overgrowth of fungus in the mouth. It can accelerate tooth decay. It impacts swallowing function, as I mentioned, and it can lead to halitosis or bad breath. Another condition that may result from poor oral health is adverse pregnancy outcomes. And that's because infections can travel through the bloodstream to the placenta. And it can result in low birth weight, premature birth, and may even result in complications in a child's development after birth. There are some other conditions that seem to have a relationship to poor oral health, not necessarily caused by poor oral health. They include Alzheimer's, obesity, osteoporosis, cancers. And it's important as caregivers to be aware that these conditions can coincide with poor oral health so that we can be proactive and try to prevent these conditions from taking place. So in my experience, making sure that the people under our care receive adequate oral health is much easier said than done, because there are all different types of barriers that we may face. So there's different types of barriers to someone being able to independently perform their own oral care regularly and properly. And Lisa's going to go more in depth with these in a little bit. But there's also barriers that have to do with the caregivers and the staff. Caregivers, especially in facilities and in programs such as ours, they really have a heavy workload. There's time constraints. They may not have enough time with each patient to always provide that oral care. They may not realize how important oral care is, and they may lack the education and training in how to properly provide oral care. Sometimes responsibilities are unclear. It's not always obvious whose responsibility it is to perform the oral care. I've had the experience where it's assumed that me as a speech language pathologist will be the one to provide the oral care, but I may only see that individual once a day, and so I'm not able to do that 2 to 3 times a day, which is what's truly needed. Dysphagia can be a barrier because people providing care are fearful that the person will aspirate, or the individual may be afraid of aspirating. There may not always be access to the necessary equipment, especially if there's specialized equipment or adaptive equipment required, and someone may not have dental insurance. So this diagram just illustrates the complexity of the rehab continuum. Someone's trajectory from injury to throughout recovery isn't always linear, and there's different challenges at each stage. For example, in the acute care setting, someone may be very, very ill, just coming out of a coma, or maybe still in a coma. They may be sedated or intubated. Their swallowing deficits may be so severe that they can't eat safely, so they have a feeding tube. But all of these people still need to receive regular oral care. And then when somebody's progressing through rehab, we're looking at their level of independence and if they can perform the oral care themselves. There's different levels of staffing at each level of care. Okay. So as I mentioned, oral care should really be performed 2 to 3 times a day, and it may be indicated that it should occur more frequently depending on that person. But just the basic tools like we all should be using would be mouthwash, toothpaste, a toothbrush, and floss. And now a Toothette, which I'm going to show, and a yank hour suction are specialized tools that you would find in the medical setting. So here's a side-by-side comparison. On the left, you'll see the kind of standard issue toothbrush you'd find in a hospital or a rehab. And then on the right, this is called a Toothette, or maybe you've heard it called an oral swab. In a study done by Marino et al. In 2016, they found that both tools are equally effective in performing oral care. However, they're not both the best options for every single patient. So depending on their needs is what we would recommend. For example, a Toothette might not be safe for someone who has a strong bite reflex, because the pink swab that you see at the top could be removed and then choked on, just as an example. So here's the basic instructions just for standard oral care. This is how we would all perform our oral care for ourselves. Just some key points. Only a pea-sized amount of toothpaste with fluoride is required. So we tend to put a lot more on the toothbrush. Rinse with water, we floss daily, and we brush all surfaces of the mouth, including the tongue. And sometimes there's some different instructions for people who have swallowing difficulties or other challenges. These are the standards. All right, so we cannot forget about denture care, because 19% of the population wears partial or full dentures, and lack of denture care can result in poor oral health. It can cause conditions such as denture stomatitis, it refers to a buildup of yeast or fungus in the mouth. And we could also have oral infections and things like that. But dentures should be cleaned thoroughly, at least once a day, maybe after each meal if there's a lot of food residue on the dentures. And something to keep in mind is that dentures are fragile. We care for them differently than we do teeth. So we're not going to use a standard toothbrush. We would use a soft brush that's intended for dentures. Standard toothpaste with fluoride would not be appropriate. We use a denture cleaner. If they're dropped, dentures can break easily. So it could be helpful to do the denture care over a bowl of water, or maybe just place a soft towel on your work surface. But what you would do is you would use the brush to remove any particles or denture adhesive from all surfaces of the dentures. And then the dentures should be placed in a cleaning solution. This cleaning solution should never be placed in an individual's mouth. That's unsafe. And dentures should not be worn overnight. So I mentioned xerostomia, or dry mouth, earlier. And I want to talk about how we can manage dry mouth, because it can cause so many issues. One common treatment would be the use of mouth and lip moisturizers. An example is an artificial saliva substitute. Maybe you've seen it. It's called Biofilm. Regular oral care actually helps to manage xerostomia because it simulates increased saliva production. Using alcohol-free products can be helpful because alcohol dries out the mucosa of the mouth. If somebody is unable to eat because of dysphagia, as their PO intake or their intake by mouth increases, saliva production tends to increase. We also want to make sure someone is hydrated. So if somebody does have dysphagia, sometimes we implement something called the free water protocol so that they can drink clean water and hydrate. So providing adequate and regular oral care for people with dysphagia is especially important, because there's an increased risk of bacteria entering the respiratory tract because of aspiration. So it helps to reduce that risk of infection. It also helps to provide stimulation to increase sensation in the oral cavity, as well as to improve that cough reflex. We talked a little bit about aspiration pneumonia and how it can be a result of silent aspiration because there's no cough reflex present. So the oral stimulation can actually help to restore the cough reflex, which is very protective and reduces the risk of aspiration. People with dysphagia may pocket food in their oral cavity, so performing oral care helps to remove any food residue, which could cause dental caries, or that residue could be aspirated after the meal. Also, the thickening agents are used for safely swallowing liquids for people with dysphagia, but they contain carbohydrates, which can sit on the surfaces of the teeth and cause decay. So it's helpful to have regular oral care, Speech therapy for individuals with dysphagia often include trials of different kinds of food and liquids that they may struggle to eat. And it's important that we keep their mouths as clean as possible so that if they do aspirate while we're trying different kinds of foods or liquids, they're not aspirating excessive biofilm. Okay, so there are some special considerations for providing oral care for people with dysphagia. I do want to emphasize, though, that everybody with dysphagia is not the same. There's a range in severity. Dysphagia could be very mild, where it doesn't even affect someone's ability to perform or receive oral care. And it could range from all the way to severe or profound, where they can't safely eat anything by mouth and all of their food is through a feeding tube. So as a speech pathologist, we would make the recommendations on how oral care needs to be performed. So we take a look at things like oral control. How well can somebody hold liquid in their oral cavity? Do they have drooling because they can't keep their lips sealed? Or is there risk of the liquids flowing back and being swallowed or aspirated? Are they able to expectorate, which just means spit? So we look at, can they swish and can they spit? If not, there are we might use a swab to absorb some of the fluid in the mouth. Again, we look at their risk of aspiration. How well do they manage liquids? Is it safe for us to even place liquids in their mouth? And potentially, their cognitive status, if we put something in their mouths, will they just automatically swallow it? Even if it's not food, if it's, say, mouthwash, might they swallow it? And then be at risk of aspirating it. Positioning is very important for providing oral care for everyone, but especially for people with dysphagia. They should be positioned as upright as possible, as much as they can tolerate, to reduce the risk of aspiration. And then for individuals who are NPO, which means they can't take anything by mouth, there's often a buildup of these deposits. It's thick and sticky, and it hardens on the surfaces of the teeth, the roof of the mouth, and on the tongue. And it can be very difficult to remove. So regular, frequent oral care helps to keep this substance from building up on the surfaces of the mouth. And it's important to keep in mind that it can be painful to have oral care performed when it's been allowed to build up and harden onto the surfaces, especially the soft surfaces of the mouth. Okay. I mentioned a tool called a Yankauer section earlier, and it can be very helpful in providing oral care safely for, for individuals who have difficulty swallowing. There we go. And the reason we use it is because it helps us to suction and manage fluids in the oral cavity so that the person doesn't have to expectorate or spit. If you take a look, this individual has been positioned upright, not exactly at 90 degrees, but elevated in the bed so that she's not at high risk of aspirating. And as oral care is being performed, this nurse or therapist is using the Yankauer suction to suction out any residue, any fluid. If this person had that thick buildup because she's not able to eat safely, then this Yankauer suction can suction up the pieces that have been dislodged so that she doesn't choke or aspirate on them. Okay. So now Lisa's going to explain the impacts of physical, cognitive, and sensory limitations on someone receiving and performing their own oral care. Thank you.
Thanks, Cerise. Hello, everybody. Thanks for joining us. So I'll just wait to. Okay. All right, so physical limitations for an individual with physical limitations, maintaining the good oral health may not be easy. So some examples that I noted here may include strength, range of motion, coordination, mobility, balance, communication, and pain. I added in this section. So for strength is needed for the individual to lift their arms, maintain a good grip on the toothbrush, floss, dentures, or to squeeze the toothpaste. Core and trunk strength is needed for sitting and standing. Should have fair range of motion in the arms, hands, neck, trunk, and facial muscles. And, in order to reach for equipment and for brushing, you have to bring the hands to the mouth, to reach over the sink. In regards to pain, somebody who has a lot of pain may not want to brush their teeth in fear that they will have increased pain in doing the activity, or maybe their pain medication makes them very tired, so then they don't participate in this activity of daily living. For communication, their pace can become an issue if the individual is unable to let their caregiver know they need to brush their teeth, or even let anybody know that they have mouth pain, or that they're fearful they could not let the dentist know what is happening when they go there. A lack of coordination can make it difficult to manipulate the toothbrush and other tools needed for brushing their teeth, and can risk injury, such as somebody that might have moderate to severe ataxia, in fear that they might poke the back of their mouth when they're brushing. Limited mobility, whether it's walking with an assisted device, no device, or using their wheelchair, they're relying on somebody else maybe to get them to get their materials that they need, or to get to the bathroom, or to even stand with them while they're brushing their teeth. So what to do? I just added a few things of some ideas. Here are some examples. If the person can't get to the bathroom and the sink, you could do the oral hygiene from the bed or sitting in the bedroom. You can use a bedside table. From the hospital, the kidney-shaped buckets to rinse into. If the individual has pain, such as back pain, maybe they need to sit and brush. Or, I've had people like open up the cabinet, the bottom cabinet on the vanity, and put one foot on the cabinet shelf, and that just takes some pressure off their lower back. It would be important to also reorganize the bathroom space so that the items are within reach, maybe a non-slip surface such as Dysphagia, or just even a towel so things don't move around, maybe mounting things on the walls. You can also remove cabinet doors under the sink to accommodate a wheelchair for somebody to get closer to the sink. In this picture, there's a little red rubber toothbrush holder that sits on the counter. It's good to prevent the toothbrush from tipping while they're putting the toothpaste on it. It's good for somebody that has decreased coordination or are only able to use one hand. I'll show you some more adaptations later in the slides. So for an individual with cognitive impairments, maintaining good oral health can be difficult as well. Some examples of cognitive impairments include memory, problem solving, attention, time management, safety awareness, judgment, and the ability to sequence a task, task initiation, and organizational skills. The individual may not have the self-awareness that they are not caring for their teeth correctly, or that they need to see a dentist because they're having pain. A person might forget or not initiate the task of toothbrushing, or forget how to brush their teeth, or is easily distracted by sound, such as somebody in another room, seeing another person, maybe the caregiver is with them in the bathroom and they're distracted talking to them instead of focusing on their teeth, or they're distracting themselves and they're looking in the mirror and then they start fixing their hair or something else. The individual may not be able to make treatment decisions, and their caregiver may feel overwhelmed or not prioritize the oral care. For higher level cognitive skills, working on scheduling a dentist appointment, transportation, managing their time so they don't miss their appointment. So what to do? So here are some examples of what you can do when somebody has cognitive impairments. In addition to some of the things I mentioned, you could provide visual cues with either simple written directions, sequencing pictures. The caregiver could do demonstration or modeling on how to do the techniques. You can provide auditory cues such as an alarm or a timer to indicate when to brush and how long to spend time on oral care. Using a planner, a calendar, or a dry erase board can assist with orientation to the time of day to brush their teeth. And as a reminder to refer back to recall that they did brush their teeth. And also, of course, to track dentist appointments. Setting a consistent routine like brushing teeth at the same time every day may be important, such as after breakfast or after getting dressed. Some other teaching techniques can be backward chaining, which is a teaching technique where the caregiver does all the steps needed for the task, but the individual completes the last step. This technique is helpful for a person with low frustration tolerance or low self-esteem, as it provides immediate success. Forward chaining, on the other hand, is when the individual is praised for successfully completing the first step, such as putting the toothpaste on the toothbrush, and the caregiver completes all the other steps. Beneficial for a person that has difficulty generalizing the skill. Caregivers should also provide simple, clear directions, such as pick up the toothpaste instead of saying maybe put the toothpaste on the toothbrush, just decreasing some of the words and allowing enough time to complete the morning or evening oral hygiene routine so that nobody's feeling rushed or getting anxious. It's good to use familiar supplies and try not to change the brand or packaging. Can clearly label the supplies so that the individual doesn't have to make a choice to figure out which item to pick up and what to use. And keep the supplies easily seen on the vanity or someplace or same place in the bedroom. Some individuals will not open their medication cabinet, or they won't look under the sink to look for things or supplies. I've had a lot of people do that. If they don't see it, it doesn't exist. They're not going to go looking for it. Okay, get my screen going. Okay, sensory limitations. So an individual with sensory processing deficits can also have a difficult time with their oral health care. So sensory processing integration is the way that the nervous system receives messages from the senses and turns them into the appropriate motor and behavioral responses. It's often seen in a lot of neurological disorders. The individual might have hyper or too much or hypo, too little sensitivity to the stimuli. For this discussion, I'm really just looking at the 5 basic senses, although there are a few others that we put in for sensory processing in occupational therapy. Many of the people that I treat following a brain injury express hypersensitivity to bright lights and colors, as well as changes in their taste and smell. This may need to be considered during their routine mouth care. Sounds that might be problematic include others talking, maybe the electric tools at the dentist or their own toothbrush, or even maybe the humming sounds from the overhead lights. The sounds may cause headaches, ear pain, or anxiety. I do have an individual who, she doesn't like the lights on, she's gonna have to turn off the lights. And then of course she can't really see what she's doing in the mirror to see that she's doing, brushing her teeth properly. Touch, even a light touch can possibly be perceived as pain, or if hyposensitive to the touch, they may not realize when they have problems with their teeth or their gums, or they may brush too hard. A person with spasticity may have pain when touched, or other limbs when their limbs are being moved. So those are things to consider. For smell and taste, can make a person, perceptions can make a person not want to brush their teeth because of the taste of the toothpaste, or they don't like going to the dentist because maybe there's a smell that they relate to the office. So, and the person may not be able to express that to you sometimes. So really looking at the environment and maybe how they're perceiving things might give you some more insight. So what to do, in addition to some of the things I mentioned, if oversensitive to light, maybe dimming the lights in the bathroom, or having the person wear tinted eyeglasses when they go to the dentist. If oversensitive to sound at the dentist's office, you can have the person wear noise canceling headphones or listening to music on their own headphones. In regards to tactile or touch stimuli, you may need to consider the texture of the toothpaste, how soft the bristles are or hard, water temperature, and the amount of pressure on the teeth and gums when brushing. If they're oversensitive to smells and taste, you can look at the flavor of the toothpaste or dental floss. The dentist's office might even be perceived as an offensive smell to the individual, like I mentioned before, and cause headaches or anxiety, and then they don't want to go. I did mention that before. And next. Okay, so I just put together some pictures. It's limited. I mean, if you Google different types of adaptations for toothbrushes, I mean, between the commercially made ones and do it yourself, there's so many variations. So I just put together a few of them. The purple round handled brush, it's called the Dex-T, is good for someone with decreased dexterity since it allows for various grips on the handle. But you can also, use a tennis ball or a cylinder foam on the handle for someone with a weak or painful grip. A longer handle toothbrush may make it easier to reach the back of the teeth if they have decreased range of motion. A brush with curved bristles that covers 3 surfaces of the teeth at the same time could help the person to be more thorough in brushing. A weighted handle can be purchased for someone with decreased proprioception or with tremors. You can even just put hand or wrist weights on depending on where the input is needed. There are many types of electric or battery operated toothbrushes that assist with a more thorough cleaning. Some have a built-in pressure sensor to protect teeth and gums, and some play music. Some have an alarm. Some have a game. You can play a game while you're brushing or vibrate to signal how long to brush, and they might make brushing more motivating for the individual. When purchasing an electric toothbrush, you got to consider how heavy it is to hold. So if someone has weakness, it could actually be too heavy for them to hold long enough. The location of the on and off buttons, so they're independent using it, and the intensity and the speed of the bristles on the gums and teeth. The brush that looks like, there's one in there, looks like a mouth guard with a black handle. That's a 360 tonic toothbrush. It actually just gets placed on the teeth. And this isn't an adapted device. This is, anybody can use it. It actually just sits on the person's teeth for 45 seconds and it covers 360. I read some reviews. It didn't have the greatest reviews, but it does avoid where the person doesn't have to actually brush their teeth. It just sits in there. So this is a video of one type of, I just thought, with technology, the way things are going, this is a Colgate Connect E1 toothbrush, and it has a smart chip inside it that connects to a Colgate app on your cell phone, and it can track where you're brushing on your teeth, how long you're brushing on your teeth each time, and how many times in a day you're brushing. You have your own little dentist on your phone, and it's interactive. It also has some video games on it while brushing, and it maps out your brushing technique to show you if you're doing a good job or not. So it'll go by 4 quadrants, the 2 upper and 2 lower, and it will color code where you're doing a good job and where you're not. The information gets stored in it for up to 30 days, and it also teaches and gives suggestions to improve brushing. I thought that was a lot going on in a toothbrush. Okay. So for toothpaste, here are some different adaptations for toothpaste. Toothpaste squeezers for someone with decreased strength or coordination can be used either with one or both hands. There's a lot of different types of dispensers that have buttons on them that you can mount on the wall, or automatic sensors, so you don't have to press anything. You can consider the size of the toothpaste tube and the type of lid, whether it be a turn lid or a flip lid. Colgate makes a product that changes color. I saw from white to blue to indicate when the user has brushed long enough. And there's non-foaming toothpaste for people that are very sensitive to taste or have swallowing difficulties. So here's some more commercial denture devices. There is a denture cream. You can use just different types of denture cream. They have adhesive strips to help with to seal it into the mouth. To clean dentures, you could use a standard cleanser tablet or a cleansing spray foam. They also have different handle denture brushes for better grip. And then here's the one-handed, in this picture is the one-handed denture brush. It suctions to the surface. You can purchase an electronic or battery-operated denture bath instead of just sitting in the cup and using the tap. So if the person's not very thorough cleaning their dentures, this is supposed to do it for them. And then we have some different types of floss. So there's floss aids come in many different types of handles and angles. You can use floss threaders, water pick, there's interdental brushes, short handles, long handles. The floss threaders also, they said, is good for bridges or braces. And so many people, so now I'm trying to switch gears a little bit. Many people with physical and intellectual disabilities may not access dental care. Just as a little review, because it's not a priority in regards to all the other medical needs that they have. The individual must rely on someone else to transport them to the dentist. They avoid the dentist due to maybe they already are expecting that they're going to have some more health problems, or they simply cannot afford it, or their insurance limits them where they can go and be seen. In addition, they may not be easy to find a dentist that specializes in people with special needs, or they're able to, given the proper time and considerations, to meet the accommodations that they need. So again, what to do? So to make dental care more accessible, you can look for a dentist that makes home visits. There are dentists that do mobile service. You can look for a dentist that specializes in treating people with disabilities. Prior to initial appointment, maybe ask questions about the office, look at pictures online, visit in advance, see what type of dentist chair they use, see if they can stay in their, if the individual can stay in their own wheelchair, especially if it reclines or has a tilt in space where they can just tilt the person back to get a good, so the dentist can get a good view and cleaning of their teeth. Also consider the office appointment times and their flexibility. So for example, a person with Parkinson's disease might want to see the dentist when their medication is most effective, when they have less tremors, less involuntary movements. An earlier appointment might be good for someone that gets easily fatigued later in the day, so they'll be less stressed, or for somebody that perseverates about their appointment. So all day they're worrying about it, so it's best to have their appointments earlier. Provide training and education either from a family member, health professional, or the individual themselves may be needed to make the appointment go more smoothly. The American with Disability Act of 1990 states that examining a patient in their wheelchair, this actually I thought was interesting, and it is cited at the end of the webinar, that a patient in the wheelchair is less thorough than seeing them on an exam table or the dentist chair, and it does not provide the patient with equal medical services. Also, a patient cannot be told that they must bring along someone who can help at the exam. And so the provider must provide reasonable assistance, such as getting them on and off the exam table or equipment, or to stay with them to maintain safety. So I thought that was interesting, because there's been a, I believe in the past where we've had an individual where they actually stayed in their wheelchair and it didn't tilt. And I remember thinking to myself, how did they really get to look into their mouth and get a good assessment? So this ADA does protect people to make sure that they're getting the correct dental care. There's also a Special Care Dentistry Association now, which is an international organization that provides education and continuing to learn more about special needs dentistry. This slide also shows, in my pictures here, I'm showing a dental chair that has a tilt for a wheelchair. So the wheelchair actually sits on the stand and it tilts. You can know some places might have a 2 armrest dentist chair, so it's easier for the person to get up front, to stand up from. You can also consider a neck pillow, a lumbar support for somebody with back pain or abnormal posture. The dentist's office may already have different styles of mouth props and tongue guards for someone that cannot keep their mouth open or has weakness. For someone with low vision or is legally blind, requesting the dentist's office to provide verbal descriptions of the office, tools, and the procedures, maybe even requesting a guide for the individual around their room for orientation to feel the furniture and tools, and that might decrease some of their anxiety. So oral care may involve different members of the rehab team. So speech therapists will identify safe and aspiration risks, train caregivers, especially for people with dysphagia, and address the cognitive impairments. Oral hygiene falls under one of the occupational therapy domains, which is activities of daily living, or ADLs. OT may need to improve. So in addition to the actual physical task of brushing, we're also looking at improving one's sitting or standing balance, motor skills, arm strength, cognitive skills, vision and visual perception, and functional mobility. We explore adaptive devices if needed, or compensatory strategies for brushing. OT may also work on higher level daily life skills, such as making those dentist appointments, setting up transportation, maybe it's reading a bus schedule, or how to use an Uber app to get to their appointments. As an occupational therapist, I've been referred in the past for an individual who had a routine dental checkup, and well, it was a poor dental checkup. And so we needed to work on him generalizing those skills in different settings, and come up with the appropriate assist device, and then provide a caregiver training. They were told the dentist wanted to brush 3 times a day. So we had to practice at the day treatment program as well as at the house. And I might have taken this slide up accident, but physical therapy as well is also going to work on balance and mobility. So obviously in turns that would help with their oral health care. Here's an example of a training I did for staff. I'm not going to read the whole thing. It does identify appropriate setup and cleanup, the equipment that was used, the level of assistance. It is important for the caregiver to know how much or how little help to give to maximize the individual's level of independence. I think that's a big thing in training for anything, and as well as with oral hygiene, is not either just doing it for them or just assuming that they're doing it themselves because they look like they're doing it, but really making sure they're doing it properly and thoroughly, and giving help as needed, and also knowing when to back up, back away, and just give verbal cues. And this is just a little more steps to brush, and I also added flossing, and I think that gets forgotten a lot because we do a lot about the brushing, but if I would say most of the individuals I work with don't floss. It's definitely forgotten, and it's a very important part of oral hygiene. So I always put that in my training, and I do work on that with people. And yeah, so then I threw in some different kinds of pictures at the end, like how to brush your teeth. These are different steps. Go to the next one. Is these pictures may help with initiation, sequencing, and motor planning. I mean, you want to consider how many steps you might need. Somebody might only need 4 steps. Somebody can do multiple steps. You can use actual photos of people brushing their own teeth. Add words to it. I think there's one more. And just again, more pictures. And then we have our resources. And that's it.
On behalf of Bancroft Neuro Rehab, I would like to thank you for attending today's webinar. Have a great afternoon.